Tuko pamoja? We're still together? Gathering important conversations or information. Now you know which doors to knock on, relentlessly, because that's what Dr. McKay has said. Where there's a will, there's a way, yeah? All right, so now to something 6, which is actually 7, which is managing rare diseases. And I think this is where a huge buck stops with the healthcare providers. We've had a lot of about them and the gaps they're in and what patients would like medical practitioners to perhaps know more about these conditions. But then again, let's hear from those that walk in these shoes, and perhaps they can also give us their perspective on the same. Now, as we know, management of rare diseases heavily weighs on the health outcomes of patients. However, it has been said here in other forums that when it comes to rare diseases, healthcare professionals are often ill-equipped to manage patients due to lack of training opportunities, lack of easily accessible information, expert advice, and optimum care pathways. So to help us understand the scope of patient management and perhaps meet the objective of this theme, which is to identify strengths and challenges of rare disease management across the spectrum, that is patient, caregiver, and the health system. We're now joined by Dr. Angela Migowa, who is representing the Kenya Pediatric Association. She's also a pediatric rheumatologist and also the assistant professor at the Gachanja University Hospital. Good to see you, Dr. Migowa. Karibu sana. We are also joined by Dr. Lucy McKay, who is representing Medics for Rare Diseases at the Kenya Medical M4RD, and of course representing the Kenya Medical Association. We are joined by Professor, or rather Dr. Kigondu. from my lips to God's ears. Please let us appreciate our panel. Dr. Kigondu, it's good to see you. I have seen you in other forums where we have talked about women and their needs. It is good to actually be able to speak about other things beyond that. And at this point, I think it is imperative that we touch on the fact that diagnostic odyssey has come up over and over again. We've heard and seen the impact of the same when it comes to rare diseases. From your experience as a practitioner, how does this impact on the health outcomes of your patients? There you are.
Thank you very much for having us. The Kenya Medical Association is a professional association of doctors whose aim is to have the highest quality of healthcare for all. When I listen to the Marfan syndrome story, and the other lady who said there's so many doctors, and eventually one of them diagnosed something, then that begs the question of, as the chief of research has said, which doctors are these? You see, we do not have a profile of who they saw. You know, we have herbalists, we have various cadres, we have, you get what I mean? So persons purporting to be doctors may not really be the people they are seeing. But at the end of the day, you want the person who has the rare disease to be diagnosed early and given the care pathway as early as possible. And that generally is done by the clinician. So we need the doctors to be, they say, I was discussing this issue with one of my colleagues who is a physician. I'm a gynecologist, obstetrician. I could not do that thing called physician because we call them here, there, they think too much. They have a lot of, these rare diseases, they are sort of an area of interest. But the mind can only see what you know.
Exactly.
Yeah, so without training, without adequate training, without adequate equipment, without adequate practice, without adequate, it's fantastic to see one of the ladies there who will speak. I think we read a lot of articles on rare diseases. We've learned a lot, but without collaboration at a worldwide level, you might not be able to diagnose some of these rare diseases. But the doctor must be trained to see such that when they see that condition, they hit the nail on the head as early as possible and treat. And speaking as a gynecologist, when the baby is born, I'm supposed to say this one will require this sort of pathway. So it's also important for the obstetricians as it is for the pediatricians.
Very well said. And just perhaps to interrogate further, wondering where or which doctors these caregivers have been seeing. You said if the doctor cannot recognize it, then they will not pinpoint it. So let's start from the basics. When these doctors are being trained, do you ever have a course on rare diseases?
And for me, and I'll come, and maybe I'll get an opportunity to come to the policies that we need pushed for. Doctors are not trained to see rare diseases. Doctors are trained to take history, physical examination, investigate you, and get the disease, whatever it is in a country. In medical school, and we go to medical school for a long time, we are trained to diagnose anything that is in the Arctic until malaria, so that you do not necessarily have to see it. But the day someone comes with signs and symptoms of Mediterranean fever, I will know, you see, because I had read it. And that's why the training of doctors takes long, you see, so that you keep repeating and you keep doing. And also the importance of continuous medical education programs, because you may never meet everything. And collaborating with people who are everywhere across the country. Yes, so we are trained to see all these diseases, even when, and maybe from a medical point of school, when Marfan syndrome, there was the gentleman with Marfan syndrome come. In fact, that gentleman might actually, he's so rare that he might actually be one of the what are called spot examinations. So you come and my professor there, hematologist, they have put that gentleman there, then they ask you, what is the diagnosis? That's part of the examination. That's how, yeah.
Okay.
So, yes.
All right, so let me bring in Dr. Migowa. We know 70% of rare diseases affect children, and unfortunately, these children do not even live to see their 5th birthday. As a pediatrician, how critical is it for you to be trained and be cognitive of rare diseases in your line of work? Dr. Migowa?
Sorry,
I think we lost you there for a second, yes?
yeah, I can see my fellow panelist Lucy also notes the same. We lost you there. Maybe perhaps you could.
Okay, so my question to you was, as a pediatrician, knowing the statistics that are working against children when it comes to rare diseases, why is it so important from a pediatric point of view to ensure that you're cognitive of rare diseases?
So, thank you, Gladys, for the question, and again, a big thank you to the organizers of this session. One of our vision actually as the Kenya Pediatric Association is to provide for all our children. And the key word there, Gladys, is all. Whether you have a common cold or a rare disease, as has been discussed for Marfan. Now, of course, as my fellow panelist, Dr. Kigondu, has said, we cannot do this in isolation because we exist in a health ecosystem. And in this health ecosystem, you have got, of course, at the center, the patient. And you know, there's a whole move towards patient-centered care. So we have the patient at the center. And then you've got the health providers, you have the policy makers, those who are in procurement. So the reason why getting the data like this is really fundamental.
You seem to be struggling with your network, Dr. Migowa, even as you rectify that. It's us?
Yes.
Oh wow, yeah, everyone hung. Apologies for that. We need to look into that connection. Dr. Migowa, continue.
Okay. You want me to take that again? Can you hear me?
Yes, we can.
Okay. Okay, would you like me to take it again?
Yes.
Okay. As I was saying, that we in the Kenya Pediatric Association, our goal is to provide an optimal health environment for all children, all, whether they have the common cold or whether they have got the rare conditions, like for example, Marfan, as was discussed. Now, for us to do this, Gladys, we don't exist in isolation. We are in a health ecosystem. And at the center of this health ecosystem is the patient. That's why now there's a move towards patient-centered care. Is the patient. And then the other stakeholders, the healthcare providers, policymakers, and those who are in supplies and procurement of medications and everything that's needed. So the reason why the data is so critical for us, Gladys, is to be able to convince the policymakers the impact, not only on the family and in the patient, but to the society as a whole, when we miss out on properly diagnosing these children and managing them. And I'll give an example. Let's take Marfan, because I've heard everyone mention Marfan syndrome. If you keep in mind the hours lost by the guardians as they move around seeking care, that's an economic loss for that family and to the nation as a whole. And then if you think through the number, I heard you mention that there's so many doctors, they probably spend lots of resources on tests and medicines, which were not beneficial to these patients, but could have been beneficial to another patient with another problem. So you see there's an opportunity cost that we are expending when we use the wrong medications and the wrong diagnostics on these patients. So data is really key, and I keep saying data is the fuel of the 21st century, because it's with data that we can convince policymakers that we need to do something to care for these children.
Mm-hmm. Now, at this point, let's hear from Lucy. And it's been said over and over again. I mean, the diagnostic odyssey is something that we need to really focus on and see how we can close in on the gap to ensure that there are better health outcomes for those living with rare diseases. From your experience, what are these tricks that we can apply here locally to ensure that we're able to bridge this gap?
Thank you very much for the question. My name is McKay. I'm from a charity called Medics for Rare Diseases. We're actually in England and Wales, where I trained to be a doctor. But even though I'm over here, I think tricks is the exact right word. And we have a different system maybe and different things in place, but people face the same issues over here despite that. And I think that some of the things that we've developed could be really translated back to help clinicians in Kenya. So, for example, we talk about think rare in the first place, and like Angela was saying, that data is so important. We need our clinicians to understand the relevance of rare disease as a whole, so that they can be suspicious of it when they think this doesn't fit. They can think outside of the box. Maybe not the first thing they think, but when it doesn't feel right, they consider a rare disease. We also say think and. If you have a child who has problems affecting many of their body systems, they have seen lots of different specialties, they have difficulties in lots of areas, and 75-ish% of rare diseases start in childhood. Rare disease becomes a lot more likely, and your population has changed, and it is appropriate to think of rare disease. And we also say, think again. Times have changed, people change, clinicians have changed. And so just because a diagnosis has been put on that patient's file, don't take it as gospel. If it doesn't fit, if the patient and family don't think it's right, if you don't think it makes sense anymore, or maybe it's a list of symptoms, it's not a diagnosis, it's a list of problems. Start from the beginning. And also, I would love you to utilise a tool that we have created called Rare Disease 101, The caveat is it's based, you know, it was created for the UK, but there are lots of messages and tools that can be used across the globe. And hopefully one day we can help, you know, provide anything we can to make that appropriate for, say, Kenya and clinicians there. There's lots of free tools on the internet that we can use. And one of them, the biggest one, I think, is advocacy, is places like Rare Disease Kenya. Because if you're alone and you don't know as a clinician, but you can go to Rare Disease Kenya, they have their network, not just in Kenya, but in other African countries, and then across the globe, they might be able to help you. To not just stop it in your clinic room and not let it go any further. Keep persevering.
I like that from Lucy, and I think this is where I'm going to put Dr. Kigondu on the spot. I mean, it has been said here that a lot of patients and caregivers have literally been the ones schooling the doctors on some of these conditions, but you will find those doctors that are totally rigid to the fact that I'm the one who went to medicine school, I should know better. So you totally refute what they have to say. From an association point of view, how can we change this narrative?
So there has been a change with that in the colonial training that Professor Gachanja had. That was it. The doctor was, but with the onset of the internet and patient empowerment, personally I love patients who know things. They tell you, you learn. First, the consultation is shorter. You can see more people, you get richer, because they know. So they are just coming to you to affirm, which is okay. And then you learn, you also learn. So it's a mindset thing. More important is what you need for us as the medical association, and therefore the doctors who are primarily seeing these patients as the first point of call, and first point of call is in quotes because they go through other systems which due to financial constraints may not necessarily have access to the doctor. So on that basis, then we would like, at the point of training, then we would like we advocate for centers of excellence. A center of excellence may be a place where you can concentrate all specific diseases into that, such that even medical students can rotate there, as opposed to getting the one which is not there. And therefore, collection of data in the same is there, and collaborations with the partners from outside is easier. As for instance, Professor does her at Gertrude, for instance, you'll know there is a station for that particular illness. You see, that makes learning easier other than you trying. Secondly, we would like engagement of specialists at the primary care level. The thinking in this country is wrong, that primary care is not curative care. It is not. Actually, when you have a specialist at the lowest level, seeing this mother with a rare condition and actually putting them on a path to the correct treatment, it saves a lot of things. It saves the mother and the whole family and the whole family. So we need a mindset change of what they call preventative versus curative. It's not a continuum, it's not different things. Therefore, for instance, we have this push to have, for instance, family physicians at the primary health care level, because a person can see you holistically and give you to the right direction. Thirdly, we have a problem with personnel. And as I said again, the person you're seeing is called a doctor. It's not necessarily a doctor. The person who has been cleaning at the hospital for 20 years, knows where injections are done, is called a doctor in the village. You see, so so we have this aspect where we need health service commission. That means that you have a body that employs, deploys, and trains. You know, lessons that keep training. Therefore, if you don't have that, then there's a break. So you have people leaving school, and the knowledge within 1 year is finished. If you're not practicing it goes. Therefore, even to diagnose the rare condition is bad. And finally, in this, what is called universal health coverage policy, what we need is a tax-funded, public-led, universal health care. Private cannot fund. I had one of the prior presenters as saying that people making a drug for 10 people cannot recoup their profits within 10 years. But the role of government is to improve the people. It is not to profit. And therefore, when they take the lead on that, then private sector can come in on that. We need to invest in research. KEMRI needs to be funded fully. We can't have the boss of KEMRI begging for money. We need research so that we can know what correct treatment to have. And finally, because it is every person's to have the right to the highest attainable care, we should avoid, we should have a good referral policy so that you see this and you know specifically you can refer. The patient, the mother with the patient should not be the one traveling. It should be the doctor sitting in a room with the patient there with a camera and, you know, traveling all over the world, not the mother taking a vehicle to look for the next doctor who you don't know whether they are able to come. So these policies are what Kenya Medical Association advocates for, and we must start at the policy level. It's very difficult to sort as an individual level. You've seen the patient. I think the whole morning you've actually seen what cost it is to an individual, and there are many. But let's pool these resources and let's have our taxes utilized for providing healthcare and funding not only NHIF but generally a universal health coverage similar to the British one. It's National Health System, I suppose.
Yeah, NHS, yes. All right, I love the way you put that in one nice topic so that we're able to close with you and move on to Dr. Angela Migowa. I will ask you to also give me, as a parting shot, as a pediatrician, we've heard today the importance of newborn screening because, as Dr. Mutinda says, many diseases can be picked up in the first year of life. For you as a pediatrician, how can this be a game changer to ensure that we negate diagnostic odyssey?
Thank you, Gladys. In the era we are in, where we are moving more towards what we call personalized and precision medicine, right? You know, days are gone when it was enough to make a blanket statement for a particular condition. That we know in any condition, there'll always be a group of people who vary and might be in the extreme end of the spectrum, for example. And what newborn screening will do, it will be able to help you pick those children who need that enzyme replacement if they lack that special enzyme. It will help us pick those children who've got that genetic abnormality. And if we can't fix the genetic abnormality, how else can we support not just this child and the family? All right? Now, the disclaimer about screening is always about the burden of the problem. What is the burden of the problem that we face? And how accurate is the test that is being proposed in picking these children with that rare disease? If we are able to get those two right, that we're able to say, okay, we postulate that we have 1,000 children with Marfan syndrome in Nairobi, for example. So then the question is, what is the best test to accurately pick children we suspect to have Marfan syndrome, given that the number is 1,000 for maybe 10 million children in Nairobi? That's the first thing to consider, Gladys. Then the next thing is, okay, if we pick these children because of our screening tool, then Gladys, what next? Because ethically, we should have a strategy in place that when I pick this child, this is the pathway through which they should go through. It is actually unethical to screen a child for something and not offer a solution. If we will not offer a solution, medico-legally, ethically, that is unsound practice. And so it's not just a matter of screening, but what will I do with the information that I have to help this child and the family? And that's why I'm sorry I keep going back to this about data. And that the more we're able to collaborate, I like what Dr. Kigondu was saying about having centers of excellence, because when you have a center of excellence, Gladys, what happens? Everybody knows all the Marfan syndrome, send them to this hospital. All right? So then that hospital will then have substantial numbers, and you can convince the administration that we get this kind of patients, this is the kind of support that we need. So I think those are the things we should keep in mind. And I know as the Kenya Pediatric Association, we have quite a number of people who work in KEMRI regarding matters of child health, and they have really done phenomenal work with other international collaborators in other areas of pediatric health that may not necessarily be along rare diseases. But I think now the onus is on us to do that. And I'll just share with the audience what we have done. I'm a pediatric rheumatologist, so I take care of children with arthritis. And what we have done, all of us in Africa who care for children with arthritis, we have come together to form a registry. Because I alone, I might only see, let's say, 50. But my sister in Tunisia, my brother in Lagos, my other colleague in South Africa will see some. So within a year, we could collect about 500 cases. And we are hopeful by the end of this year, we will have data for the continent when it comes to childhood arthritis and all its associated conditions.
Amazing. Data is key. All right, even as we close, Lucy McKay, perhaps you're parting short all the things mentioned here are possible, things that have been done in other parts of the world. What would you like to say as your last word?
I'd just like to say that 40 years ago today, my brother died of a condition that now in the UK can be treated with enzyme replacement therapy. And that has been because of research, lots of which is to do with patients, families, and advocacy driving that research. And so it's a pleasure to just to be here. So thank you, and to hear your words, both of my panel members. I would just like to say on screening, the UK has had screening as an ability for a long time, but we stopped adding conditions. We still have a diagnostic odyssey. Screening is so vital, and I'm excited for the prospects in Kenya, but it has to go hand in hand with education, because what we've seen in the UK is medical education is lagging so far behind now in comparison to, in comparison to treatments, in comparison to the power to diagnose with diagnostic tests. Really, a lot of the time, people are being held up because of a lack of medical education. So I really think from the very beginning, in the UK, our medical school sounds a bit similar, where you maybe pick one, a few rare diseases, but we need cross-rare disease education that states to our future workforce why rare disease as a whole matter. Again, that comes down to data. And I think that education piece, not just about single rare diseases, but about rare disease as a total and what you can do, has to go alongside these exciting developments. Otherwise, like here, we are still debating the diagnostic odyssey. And frustratingly, we have a lot more power. England has a genomics medicine service. If genomics was going to solve the problem, then there would be people who have conditions that have been able to be tested for decades, not experiencing the diagnostic odyssey, and yet they are. And that is why it has to go hand in hand with education.
Very well said, Dr. Lucy McKay. Thank you for joining us, Dr. Angela Migowa, and of course, Dr. Simon Kigondu. Really, this was a very informative session. Thank you all for being part of this and being so passionate and enthusiastic in changing the narrative of care in this country. Please, let's appreciate these medical practitioners. Oh, now we're finally on the final leg of this workshop, and